good evening and thank you for joining us again. Uh, Very extensive, very fruitful conference so far. Yet we have a very good session. This one is on the exclusive human milk diet, and we have very two eminent speakers, which I will introduce. This workshop is sponsored by one of our major sponsor, PROLACTA Bioscience. So it's my great pleasure to introduce Dr. Melinda Elliott. She's joined the PROLACTA Bioscience in 2016 and currently the CMO there. After holding the professional and clinical position at the Johns Hopkins Hospital and Franklin Square Hospital, she joined the faculty at the Samuelson Children's Hospital at Sinai and the pediatrics medical group. She has researched the benefit of an exclusive human milk diet for very low birth weight premature infant in the NICU and is published in academic journals. Dr. Elliott is an experienced neonatologist, educator, mentor, and leader in the neonatal intensive care. Dr. Elliott earned her MD degree from West Virginia University School of Medicine and completed residency training program in pediatrics, a faculty position as chief resident in pediatrics, and fellowship training in neonatal perinatal medicine at the University of Florida. So it's my pleasure to welcome you, Dr. Melinda Elliott. The floor is yours to start your talk.
Thank you so much, Dr. Khan, for that wonderful introduction. Yes, I am currently a practicing neonatologist and the Chief Medical Officer for PROLACTA Bioscience. I am joined today by Andy Markell, who is also our medical science liaison. She is a registered dietitian as well and has many years experience and multiple publications with the use of the exclusive human milk diet as well. In terms of disclosures, I had none until I joined the company in August of 2016. The research you will hear about was not in any way supported by PROLACTA at the time it was done. Andy also had no disclosures until she joined the company in 2018. She had no support as well from PROLACTA at the time of her studies. We believe sincerely that breast milk is for babies and cow's milk is for cows, and this is particularly applicable to infants who are born extremely prematurely.
Okay, so what is the exclusive human milk diet? The diet is one that is made up of 100% human milk derived products. So that means that preferably we want to use mom's own milk. And that milk is going to be fortified with a human milk-based fortifier. In the absence of mom's own milk, we have a human milk-derived formula. And anything else that you add to the diet, whether that's protein, fat, or carbohydrate, it all must be made of human milk in order to have an exclusively human milk diet. Next slide, please. And here are some examples of the exclusive human milk diet. On the top, you'll see fortifiers. So these are made of human milk and are to be added to mom's own milk. On the bottom, to the right, you have, in the absence of mom's milk, are human milk-based formulas. And then over to the left, we have a caloric fortifier. So that's Humavant CR, which only provides calories. Next slide, Melinda.
So I'm now going to briefly discuss the benefits that have been reported in the literature, including the benefit to reducing incidence of many of the major morbidities that these infants face. And just to be clear, we are predominantly talking about very low birth weight infants, those under 1,500 grams, and even more significantly, those under 1,250 grams. And not only do these morbidities have financial costs, these have social and emotional costs as well as physical costs for these infants. One of the biggest studies that has been done that was published in around 2016 in the literature came out of a multi-center retrospective cohort study that included infants in 4 centers in 4 different states in the United States. And all infants in the study were under 1,250 grams at birth. And what the authors found was that when these infants were given the opportunity to have an exclusive human milk diet, compared to a diet consisting of mother's milk and fortified or supplemented with a cow milk product, these babies had significantly lower necrotizing enterocolitis, lower mortality, lower late onset sepsis, lower retinopathy of prematurity, and lower bronchopulmonary dysplasia. And this is the data table from that article. And I think you can see that there is significantly lower late onset sepsis, ventilator days, retinopathy of prematurity, PDAs, and BPD. This is the study from our institution. And when we decided to bring on the exclusive human milk diet in our unit, we studied, again, a retrospective matched cohort. And what we found that most impressed us was that feeding intolerance almost went away. And just to orient you to this slide, we defined feeding intolerance in our unit as infants who, for clinical symptoms of bilious emesis, abdominal distension, or bloody stools, had their feedings stopped for at least 24 hours. It had to be 24 hours for an infant to qualify as feeding intolerance in our study. This first column, which says human, are infants receiving the exclusive human milk diet. The next column is mother's own milk, fortified with a bovine or cow milk fortifier. The next column is what we call the mixed group. These are infants whose mothers had some milk, but not enough. The mother's milk was fortified with a cow milk-based fortifier. But when there was not enough mother's milk, they received a cow milk-based formula as a supplement. And then the last group were infants who received only formula, whose mothers were not able to provide any milk. One thing I do want to point out is that the formula group in this study was significantly more mature than the other three groups. These babies were approximately 30 weeks gestation in the formula group. And though they were small, I would expect them to do better because they were 30-week infants. The other three groups were all 28-week infants. And I think you can clearly see from this slide, the gray bar means there was never any feeding intolerance. So even comparing just to babies who got all mother's milk with a cow milk-based fortifier, the human milk-fed infants had so much better feeding tolerance. What this feeding tolerance sort of correlated with in our unit was 9 to 10 day longer time for an infant to achieve full feeds. 9 to 10 days more TPN, 9 to 10 days more central line days over and above the human milk-based group. They also were in the hospital longer. The human milk-fed infants, the kids who received an exclusive human milk diet, were in the hospital for the shortest length of time. The mother's milk fed with the cow milk fortifier group were in 4.5 days longer, the mixed group 3 weeks longer, and the formula group a week longer. And you might remember I mentioned this formula group was 2 weeks more mature. So this human group were 28-week infants, the formula group were 30-week infants, and yet they still were in the hospital 7 days longer. We also saw significantly less ROP and BPD in the human milk group when the statistics were adjusted for gestational age. And this is just the gestational age I referred to earlier. The formula group was significantly older at 30 weeks. The others were all right at 28 weeks. And so this actually, the ROP and BPD secondary outcome data went right along with what Dr. Hare found in that Texas Children's study with the 4 centers and the 1,600 infants. Yet another article that came out not long after this was again out of Texas Children's Hospital, and it was a prospective randomized trial involving the use of cream. And you might remember Andy mentioned that cream product, which is a fat supplement derived from human milk fat. Dr. Hare in her institution, as well as those in San Antonio, Texas, a different institution, did a prospective multi-center randomized trial where they looked at infants who were 750 to 1,250 grams. Both groups received an exclusive human milk diet. The difference between the groups was in the cream group, if the mother's milk or the base milk the infant was receiving was less than 20 calories per ounce or 67 calories per deciliter, then these infants received the cream supplement to bring the caloric density up to where we assume that it is when we make some assumptions using mother's milk. In addition, they also did a sub-analysis of some groups, some kids with BPD. And what they found was actually striking. The only difference between the feeding protocols in these two groups was whether or not the base milk was brought up to a level caloric count. And what they found was that post-menstrual age and discharge and length of stay were both decreased significantly in the group receiving cream. Now, these groups were both the same gestational age to start and were well matched for gestational age and morbidities. So the cream group got home earlier. When they looked at infants in the subgroup of BPD babies, the kids with BPD seemed to do even better. Now, this was a smaller group, so they did not reach statistical significance at the 0.05 level, but they did reach significance at the 0.08 level. So perhaps infants with BPD who are supplemented with human milk-based cream products do even better.
Okay, so now we're going to talk about avoiding cow milk and feeding earlier. Does it really make a difference? Next slide, please. So when you think about fortifying with human milk fortifier or HMF, the cow's milk-based HMF, think about a little volume, whether that's powder or liquid, added to mom's milk. So you're not really adding very much. However, when you look at what that means to the components of the milk, it really does make a big difference. On the left here, we have an example of mom's own milk mixed with cow's milk-based human milk fortifier. And while you're adding just a little bit of fortifier to that milk, what you've done is now created over 50% of the protein as a cow's milk-based protein. However, if you look on the right, you can see when you add a human milk-derived human milk fortifier, you keep 100% of the protein as a human milk source. Now, we can see that visually here it makes a difference, but does it make a difference clinically to the babies? Next slide, please. Well, here's a study by Dr. Lucas, who you heard earlier in this conference. And here he looked at an analysis of prospective babies that had previously been analyzed, 114 infants. But what he did in this analysis was look at babies who all of them received their mom's own milk. And the only difference between the two groups of babies were the fortifier. So one group of babies was fortified with cow's milk-based human milk fortifier, and the other with the human milk-based human milk fortifier. And what Dr. Lucas saw was that the babies who were fortified with the cow's milk-based human milk fortifier has a significantly higher incidence of NEC and also a higher incidence of combined morbidity index of NEC, surgery, or death. The cow's milk-based fortifier babies also had lower head circumference statistically. Next slide, please. At this conference, you've also heard from Dr. Houston, and this is his publication from this year, 2020, where he brought 4 different centers together and had a combined 394 babies. And what they looked at in this paper was all the babies got an exclusive human milk diet. So they all received the human milk-based human milk fortifier or formula. But what we see is that the difference in these two groups is just fortifying earlier, less than or equal to 60 mLs per kilogram per day, or greater than 60 mLs per kilogram per day. And what they were really focused on was, what does fortifying early really mean for the baby? Is there a difference? Next slide, please. And what we can see in this table is that the earlier fortification group had a statistically significantly lower incidence of chronic lung disease, as you can see with the first circle in the top. Another interesting finding was that even though all these babies got the exclusive human milk diet and were fed the same type of feeding, the babies who were fortified earlier didn't have a higher incidence of NEC. So really the NEC incidence stayed the same whether you fortified earlier or you fortified later. Next slide, please. And here you can see that there was a statistically significant difference in the growth velocity between the two groups. Although the numbers are small, the early group did have a significantly higher weight gain velocity than the group that was fortified later. Next slide, please.
So now I'd like to talk about a small study that came out of Canada a couple years ago called the O'Connor trial. And what they looked at in Canada was they intended to do a prospective head-to-head comparison in a randomized controlled trial looking at cow milk fortifier versus human milk-based fortifier. And unfortunately, it was only a small trial of 127 infants. It was a well-designed, prospective, blinded, randomized trial. The infants were right around 27 weeks and just under 900 grams in both groups. The problem here, as you may guess after hearing the data, is that fortification started not until day of life 16 at 120 milliliters per kilo per day of feedings, and parenteral nutrition was discontinued at the same time. And as Andy mentioned in the previous study, early fortification is safe and makes a difference in terms of growth and outcomes. And what this study found, despite the late fortification, was a statistically significant reduction in severe ROP from 10.7% in the cow milk fortified group to 1.6% in the exclusively human milk fed group. Additionally, they found a reduction in the mortality and morbidity index, as they defined it, from 49% to 36%, but this did not reach significance at the 0.05 level, only at the 0.07 level, putting in a suggestion that perhaps the study was not large enough. And lastly, they did find a reduction in late onset sepsis. It was cut in half. However, again, due to study size, it was not statistically significant. But for me, which goes along with the study that Andy just talked about from the Houston group in Oregon, this study showed in their supplemental data these growth charts. And this can only be found in the online supplemental data. And what it shows are the Z-score charts for weight, length, and head circumference growth from day 1 of the study, which was the first day of fortification, remember day 15 of life for these infants, to the end of the study, which is the day they weaned off of the exclusive human milk diet. And there were no differences in growth between the two groups. But what I noticed when I look at this is something that I've personally noticed in my unit. Weight gain is essentially the same, whether you use a cow milk or a human milk-based fortifier. Length and head circumference in this study, and these charts show the human milk-based fortifier as a solid line and the cow milk-based fortifier as a dotted line. You'll notice that in both length and head circumference Z-scores, the human milk-based group starts out a little below the cow milk-based group. By the end of the study, both the length and the head circumference have surpassed the cow milk group. Now, this is not a statistically significant finding, but what we have seen clinically, what Dr. Amy Hare at Texas Children's describes, what Dr. Houston has described, is that these children are long and lean and are not obese, and they look like they're doing very well. The next study I'd like to discuss is another study that came out by Alan Lucas and Steve Abrams this year. And what he looked at was the safety of cow milk-derived fortifiers used with an all-human milk-based diet versus very low birth weight preterm infants. And this is different from the one that Andy described in that this is a meta-analysis of the data that is available in looking at the modern era of fortification. So only studies where the base milk is 100% human were analyzed. So there are only 3 of those. The O'Connor published results that I just showed you, and then Dr. Lucas obtained the raw data from the very first Sullivan trial, which was a prospective randomized trial, and the Assad trial. And he took that raw data and only looked at the infants who were exclusively human milk fed as a base diet. He excluded infants who were cow milk formula fed. He also excluded studies done before the modern era of human milk-derived fortifiers, many of which Dr. Lucas himself did in the 80s. And so with this meta-analysis, there were a total of 453 infants. Also of interest in both the Sullivan and Assad studies, there was only mother's milk in the cow milk fortifier group. And as you know, in the US, we use donor milk, but in those 2 data sets, only mother's milk was included. And what he found was basically data that corroborated his assertion that cow milk is dangerous for these very tiny babies. So if you look at these plots, you'll see to the right of the vertical line favors the human milk-based fortification, and the left favors cow milk-based fortification. And that is applicable to the next couple slides. For necrotizing enterocolitis, there is a significant risk to giving cow milk or a significant benefit to giving only human milk. For retinopathy of prematurity, we are seeing the same thing. Again, human milk is significantly better. For PDA presence, same thing. And for feeding intolerance that we described in our Assad study from my nursery, all of those things are significantly better if you feed human milk compared to a cow milk-based fortifier. And then when Dr. Lucas looked at the same mortality and morbidity index that Dr. O'Connor created for her study, which means an infant gets a positive if the baby has death, sepsis, NEC, ROP, and or BPD. That is a positive response on the mortality morbidity index. He used that index and looked at it for all 3 studies. And when he combined those in a meta-analysis, you see that it is significantly favoring human milk. And he believes this shows clearly the adverse effects of a cow milk-based fortifier, and that these adverse effects occur despite pre-fortification with a 100% human milk-based diet.
Okay, now we're going to talk about growth on the exclusive human milk diet. Next slide, please. So here's a study by Dr. Hare from Texas Children's Hospital. This is a prospective observational study where she looked at 104 infants who were all fed the exclusive human milk diet. And what she wanted to do was monitor their growth, so their weight gain, length, and head circumference, when they're receiving an exclusive human milk diet, when you're fortifying at 60 mLs per kilogram per day, and advancing appropriately and continuing on the exclusive human milk diet until 34 weeks. Next slide, please. And in these results, you can see the 104 infants that Dr. Hare studied in the second column, and you can see that their weight, length, and head circumference compared to a previously published study that Dr. Elliott talked about, the Sullivan study. And you can see when fortifying early and advancing appropriately, you do have very good weight, length, and head circumference. But even if you were to calculate the weight gain slightly differently using the exponential formula, you would still see an increase in weight gain compared to the Sullivan study. What's interesting when you look at the Sullivan study is there's 2 different arms, one where they fortified earlier at 40 mLs per kilogram per day with the exclusive human milk diet, and one where they fortified a little bit later. And even in the third column compared to the fourth, you see improved growth when fortifying early. Next slide, please. Here is an example of the feeding protocol that Dr. Hare uses at Texas Children's Hospital. And you can see where that arrow is indicating that they add Humavant plus 6 at 60 mLs per kilogram per day. In the previous study that I mentioned, they were adding Humavant plus 4 at 60, but even with a higher concentration, now they're able to fortify at 60 mLs per kilogram per day in this example of their protocol. Next slide, please. In this study by Dr. Houston, who I worked with in Oregon, this study is looking in 2018 at really growth, focusing on growth and fortifying earlier in the protocol. Dr. Houston published a study in 2014 that really looked at decreasing NEC by using the exclusive human milk diet. And in that study, we fortified at 100 mLs per kilogram per day. In this study, we wanted to see if fortifying earlier at 40 to 50 mLs per kilogram per day would improve our weight, length, and head circumference gain. We had 3 groups. All the groups got mom's own milk. In the first group, the backup to mom's own milk with cow's milk-based human milk fortifier was formula. In the second group, it was mom's own milk or donor milk with cow's milk-based human milk fortifier. And the third group was the exclusive human milk diet. Next slide, please. Here you can see that the NEC rate from all 3 groups, the preterm formula group, which is the second row, the donor milk or mom's milk group, which is the third column, and then the fourth column is the exclusive human milk diet group. Even fortifying earlier, the exclusive human milk diet group still had the lowest NEC rate, meaning that fortifying early did not increase NEC rate. And you can see with the other statistics below with weight, length, and head circumference in the exclusive human milk diet group, like Melinda suggested, length gain is the same practically as the backup of preterm formula, as well as head circumference is almost the same as the preterm formula group, and both are higher than the donor milk backup group. Weight gain does look a little bit lower than the preterm formula group in this study. However, it was improved compared to the study in 2014. Next slide, please.
Thanks, Andy. Now I'm just going to talk a little bit about some of the long-term outcome data that's out there. Since the PROLACTA company has only been around about 10 or 15 years, we don't have a lot of long-term data, but what we do have is very encouraging. historically, I'm sure you all are well aware, we struggle with small infants, particularly small for gestational infants, having abnormal metabolic outcomes as they grow. It puts them at risk for obesity and perhaps type 2 diabetes as adolescents and adults. There is some early data about heart disease being significantly higher in adults who were not given human milk as infants. So this study was done out of Texas Children's again. They are one of the biggest academic centers that have been using the products the longest. And it is a study looking at small for gestational age infants versus appropriate for gestational age infants, looking at their 2-year catch-up growth and their outcomes. It is only a single center study and not a very large one that had 33 AGA and 18 SGA infants, all of whom were born at less than 1,250 grams. They all received an exclusive human milk diet until 34 weeks of gestation, and they all received a diet that gave them at least approximately 4 grams per kilo per day of human milk-based protein. And what they found was that both the AGA and the SGA infants who were fed an exclusive human milk diet had acceptable growth at 1 and 2 years of age. The SGA kids caught up slightly later, between ages 1 and 2, but they had greater catch-up growth without the increased adiposity or increased insulin resistance we have seen in the past in these children. So by 2 years of age, not only were they caught up with the AGA kids, but without the abnormal body type. And what Dr. Hare and her team felt was that an exclusive human milk diet may therefore improve long-term body composition and metabolic outcomes of these very low birth weight infants, particularly SGA infants. Another paper that came out of, again, Texas Children's by Dr. Bergner et al. Looked at growth and body composition as well as neurodevelopmental outcomes at 2 years of age among a different group of preterm infants. This was only a pilot study. These were tiny babies, just under 28 weeks, just under 900 grams. They received the exclusive human milk diet until 36 weeks. They were followed at 12 to 15 months and 18 to 22 months. What was found is that their Z-scores returned to birth levels by 12 to 15 months. So they did go home smaller in Z-score than they did when they had when they were born, but they were back up by 1 year of age. Additionally, body composition at 2 years of age was similar to term controls. So no longer were they starting to see these preterm infants with excess abdominal fat. There was no increase in fat mass in these groups and similar lean mass to matched term controls. The weight gain from birth to discharge in the hospital correlated with their bone mineral content, their lean mass, and their fat-free mass at 18 to 22 months. Additionally, none of these infants in an albeit small group had cognitive composite scores on the Bayley-3 of less than 70, indicating severe impairment. And these are their growth charts for the first 5 years of life in another study that was done. So this is a 5-year follow-up by the same Dr. Bergner, a different group of preterm infants. And I think you can see that these infants were discharged home a little lighter Z-score wise than they were born. Length was down as well. But of interest, by 1 year of age, again, in this study, they had come back to birth levels. And by age 5, they had remained there. Interestingly, the 5-year-olds here, and this is not a big group, were actually a little taller. And Dr. Hare jokes frequently that the only complaint their parents have is that they all need belts to hold their pants up. This is the body composition data at age 5 compared to matched full-term infant controls. So these are all 5-year-olds getting body comp. And the important thing to note here is that there are no differences between these very low birth weight premature born infants and the matched term controls at age 5. Bone mineral content and density, fat mass, fat-free mass are all the same. And their neurodevelopmental outcome scores are pretty good. The average IQ score for these kids is in the mid-90s. And these are all infants, remember, who are born at an average of less than 28 weeks. And then there was a follow-up to that cream study I mentioned where those infants grew and got home earlier in the hospital. They followed these kids at ages 2 and 5, looking at whether they received the cream product or no cream. And what they found was that at age 2 and 5, The cream group had body composition, growth, and neurodevelopmental outcomes similar to term controls. And the cream group had a higher bone mineral density and a trend toward increased lean mass. I know historically we've all been afraid to feed too much fat to these infants, but it at least appears in these small studies that human milk fat is metabolized quite differently from any other type of fat in these infants. Additionally, while there was no statistically significant difference in this group between the cream and the no cream group, the dark bars are the control group who did not receive cream. The light blue bars are the cream group, and these are their IQ scores. Again, these are not significantly different, but I think you'll see that in every level, the light blue bar is higher, indicating a higher IQ score than in the dark blue group. And then another story, this is actually my favorite recent publication that was presented last year at PAS and has been submitted for publication now. It is a retrospective multi-center cohort study of exclusively human milk-fed infants versus those who received a cow milk-based fortifier. It's 252 infants in 6 centers in the US and Austria, and they were evaluated at 18 to 22 months. All of these kids received a protein intake in the NICU of about 4 grams per kilo per day of human milk protein, and they were transitioned to a mother's milk with cow milk-based fortifier or a cow milk-based formula product at 34 weeks gestation. And what they found in their 2-year outcomes is that their Bailey cognitive composite score in the human milk-fed group was 7 points higher on average than the cow milk-fed group. So the authors believe this is an early indication that exclusive human milk certainly may have an impact on improving cognitive scores in these children over the cow milk fortifier. Now you might wonder why. What could possibly be occurring in human milk that is not present in cow milk? And I know we've all been talking for a long time about DHA intake in small infants, and a number of the formula companies are actually adding fairly high levels of DHA in their products to try to meet what would normally be accrued in utero. And this is just a very small study that was presented this year at the 2020 PAS meeting, which was held virtually. It is a study out of Texas Children's and Beth Israel Deaconess in Boston, where they looked at 31 infants in 2 centers. In the Texas group, they received an exclusive human milk diet. In the Boston group, they received human milk fortified with cow milk. So the only difference between these groups are they were treated in different major medical centers, and one group received all human milk, the other group received a cow milk-based fortifier. Both groups were right around 27 to 28 weeks at 960 grams birth weight. And what they found was the human milk-based fortifier group maintained their birth levels of DHA without added supplementation, and also maintained their levels of linoleic acid to DHA ratio. The cow milk fortified group had a 30% drop in DHA levels from birth. The arachidonic acid levels dropped in both. The conclusion of these authors is that the human milk-based fortifier improves the DHA status in very low birth weight infants compared to cow milk-based fortification. Now, this is in no way a definitive answer as to why we're starting to see a signal for better neurodevelopmental outcomes. It does provide us with a clue as to the physiology of why these infants may do better if their DHA levels are maintained from birth. And lastly, I just want to introduce you to something that we have created this year, Andy and I, through our experience with the products and through an extensive literature review. We have created the PROLACTA exclusive human milk protocol that we believe would provide patients with the best and safest outcomes. So initially, we recommend that you start feeding on the first day of life if the patient is clinically stable. Things to consider when determining which feeding advancement rate you should use are gestational age, birth weight, whether or not there was significant intrauterine growth restriction, in other words, less than or equal to the 3rd percentile at birth, what the infant's APGAR score was, and whether or not the baby received cardiopulmonary resuscitation at the time of delivery, whether the mother is an illicit drug user, whether the infant needs significant pressor support for blood pressure, and whether or not there is a hemodynamically significant PDA. Just to remind you, these are the products that we're talking about. Now, I really want to point out these two in the middle, the Humavant +6 products. One is just a smaller volume than the other. This is the cream product. These are fortifiers. This is a fat modular. And these are the ready-to-feed human milk-based formulas. If the infant is severely ill, in other words, you have great concerns about his or her ability to tolerate feeds at all, we recommend starting feeding on day of life 1, or you could provide 1 to 2 days of a trophic feeding volume. We recommend starting at 10 cc's per kilo per day and advancing every day by 10 per kilo per day until you reach day 5, when you go up by 20. By then, the infant should be stooling. Now, what should you start with? Mother's own milk. If you have mother's own milk, you absolutely should be starting with that. If you do not have mother's own milk, it is perfectly safe and well tolerated to start with the human milk-based ready-to-feed Humavant formula in either the 24 or 26 calorie per ounce version. Both have the same osmolarity. Both are tolerated equally well. It really just depends on what your protein intake target is. After you reach day 5, you will be at 60 cc's per kilo per day, and we recommend fortifying at that point with the Humavant +6 fortifier if you have mother's milk, or changing to RTF ready to feed 26 if you had previously been using 24, and continue to advance by 20 per kilo per day until you reach 160 cc's per kilo per day. If your baby is a relatively healthy but just tiny preterm infant, not with one of those risk factors I previously mentioned, we recommend starting feeds on day 1 at 20 per kilo per day and advancing every day by 20. And it's the same regarding using mother's milk, fortifying when you hit 60 per kilo with +6, or starting with the ready to feed 24 or 26 and changing for sure to 26 when you hit 60. If the babies are bigger, let's say over 1 kilo, and otherwise doing quite well, we recommending following the SIFT trial advancement rate of 30 per kilo per day, which allows you to fortify these infants on day 2 if you have enough mother's milk. If you don't, you can use the RTF 26. A couple of reminders: these infants will need supplemental vitamins and minerals. We use 0.5 milliliter of infant multivitamin drops twice a day, and we add supplemental iron equal to 2 to 3 milligrams per kilogram per day. We also recommend adding Humavant CR or the cream product when you discontinue your lipids. And any of the following apply. You may have inadequate calories, you may have extended feeding infusion times, you may have poor growth, or if you have an infant who seems to have a very high energy expenditure. You can always add more cream. It is very important, though, that you are meeting your 4 grams per kilo per day of of protein intake. You transition off the exclusive human milk diet around 34 weeks to whatever the infant would be going home on, and you do that gradually over a 4-day period so that there's no intolerance issues. So that's it for our presentation. These are a bunch of PROLACTA kids, and we welcome your questions.
Dr. Linda and Merkel, very nice, comprehensive review on the exclusive human milk. We have a couple of questions. The first question is that you mentioned it, but they want to know that what is the ideal time for fortification in a very smaller babies, because there are many deviation in that. Some say when it reaches 60 per kg feed, but some say 100, 90. So what is your recommendation on that?
Want me to take that one, Andy?
Sure.
Yeah.
So that's a great question. Part of it is there's historically a sort of an uncomfortable feeling when we fortify in the past with cow milk-based fortifier. I know I personally have experienced it. When we first started using the human milk-based products, we fortified at the same time as we used to do with our cow milk products. Over time, we learned how well tolerated the products were, and that was unnecessary. And we have moved way down in when we fortify. Most of the really large units and my own unit, we fortify now at 60 cc's per kilo with the +6 product. Some institutions, the one Andy used to be at, they actually fortify at 20 cc's per kilo with the +4 product and then use the +6 at 60. So it's really what your unit can agree on, but work toward at least a 60 cc per kilo fortification with +6.
Okay, very good.
I completely agree.
Yes, Merkel, you want to add something? Andy, you want to add something?
Oh, just that I completely agree with Melinda. My experience is exactly the same. We started fortifying at 100 mLs per kilogram per day. And then when we experienced the tolerance or the lack of intolerance that the fortification, using this type of fortification gave us, it was, we felt comfortable and slowly moved the dial back. So we, fortified at 100 starting, then we did 80, and then we did 60. And then like Dr. Elliott said, now we fortify at 20 mLs per kilogram per day on day of life 3 if feeds start on day 1.
Okay.
So I would say those 60 is the goal.
Sure, very good. There's another question. Is there any contraindication for fortification? For example, if the baby has the milk, mother milk, so is any contraindication you think of that the fortification is not recommended?
I do not. I know there is some discussion, particularly out of one of the thought leaders in the UK, that these infants don't actually need fortification if you have all mother's milk. I completely disagree with that. And I think most of the data that's out there shows that no matter what volume you feed of mother's milk, you really can't hit the protein and even more importantly, probably the calcium and phosphorus goals that infant needs to build bones. So you could feed it 220 cc's per kilo per day and maybe hit the protein goals, you still won't reach calcium and phosphorus goals.
Okay.
And for me, if I can just add,
Sure.
I don't feel like there's a contraindication to adding fortifier because essentially what you're doing is feeding human milk. And it's the osmolality is so low and it's so well tolerated that I really don't see a contraindication.
Okay. The another question for both of you is what is the protocol of weaning from the fortification? So let's say the 24, 25 weeker around age of 34, 35 discharge home. So you continue the fortification or what is your protocol on that?
We wean, and everybody has to wean at some point because the products are only available in the hospital. So at 34 weeks, we wean gradually. By that time, the kids are usually on 8 feedings a day, every 3 hours. And so on the first day of weaning, we substitute 2 of those exclusive human milk feeds with one with either a cow milk formula or a cow milk fortifier or just mother's milk. And then the next day we do half of the feedings that way. And then the third day of weaning, only 2 feedings are exclusively human milk. And by the 4th day, they're on formula or mom's milk with a cow milk fortifier.
Andy, you have any comment on that?
That's it. We're exactly the same. So we transition the feeds similar to Dr. Elliott and at 34 weeks so that the patients have time to tolerate something else before they go home.
Okay, this is also the interesting question that let's say the mother milk, the breast milk is not available and the baby delivered 26 weeker or 25 weeker and you start with the PROLACTA. Now the baby going home. So if it is not available, then he has to be on the cow milk formula. So how you see that thing?
Yeah, you're absolutely right. We transition those kids in the exact same fashion, but we go from the Humavant ready-to-feed human milk-based formula to whatever cow milk formula they would be going on at home. Again, at 34 weeks, gradually over 3 to 4 days. Same thing. And we've actually had no trouble with weaning if you wait till 34 weeks.
Okay. Okay. The another question is, what is the role of supplementing iron in addition to the fortifier?
You must supplement iron and vitamins. Absolutely. You need supplemental vitamins and you need supplemental iron. We add our iron at 2 weeks of age. We add our vitamins as soon as they reach full feeds.
Okay, this is a technical question. It is from me that you reconstitute this PROLACTA formula. Is it affect the real efficacy of the breast milk, where you can compare it with the mother's own milk? Because of course there are some preservatives which increase the shelf life, and there must be some difference. So where you can understand that if on the scale of 1 to 10 with the breast milk, I mean,
So
mother milk.
yeah, so first of all, there's nothing better than mother's milk. Absolutely,
Yes,
100%.
absolutely.
We do not add preservatives. The product is frozen. However, it is pasteurized. And pasteurization does decrease some of the bioactive components that are present in naturally occurring unpasteurized mother's milk. More bioactive components are there than in, say, a cow milk product, certainly. Not quite as good as mom at all, but depending on which product you're talking about or which component you're talking about. Human milk oligosaccharides, for example, are completely preserved. And because the pools are large, those oligosaccharides are present in a wide spectrum and appear to be protective. And one of the reasons that the microbiome develops better in infants who are fed a wide spectrum of HMOs. Something like lactoferrin, for example, is decreased by pasteurization. Obviously, there are no cells present. Pasteurization and freezing get rid of the cells and completely change this product so that it is not at all plain mother's milk. So mom's milk is best. This is the next best.
So the last but not the least, you heard of the selective fortification by Professor Adamkin, that they have a milk analyzer. So let's say if I have 26, 27 weeker, I have the milk analyzer, and then I fortify accordingly. Do you think it is a good idea?
You know, I think there's a lot of discussion right now about this targeted fortification that you're referring to. It's an interesting concept. I think if everybody had a milk analyzer, you could certainly give individualized nutrition to an infant. The Humavant products are so variable that you could use them safely still and give them early and figure out what your patient needs. There is a study right now going on in Sweden where they're actually doing just that with the Humavant products. It's a prospective randomized trial with targeted fortification looking at our Humavant products versus a cow milk product. So we should be hearing about that one soon.
Sure. With that, we will conclude that because of the timing. There are a lot of questions. I think we have your emails, both Andy and Melinda.
Yes.
We will forward it to you. And
Great.
Thanks a lot. It's a very comprehensive, really a good overview on the breast milk or the mother milk nutrition to the babies. And thank you, PROLACTA. I am seeing Mr. Vincent Gasper is on there. So thank you for your support to our conference. Thanks a lot. We will start our next session in a minute. You are most welcome to join us in our cardiology session.
Thank you.
Thank you.